Waalaikumsalam, Doktor.
Okay, so I'll be listening. I'm still on the way sending my daughter. I'll just off my mic, but I'll be listening. Okay, just go on with the presentation. Okay, let's begin our seminar with recitation of Surah Al-Fatiha. Then we can begin.
Assalamualaikum warahmatullahi wabarakatuh. We are from Group 7. We present seminar entitled Personality Development and Personality Disorders. Next. Next slide.
Dia hang ah.
Okay. Okay, so next. Okay, so let's focus on the personality development first. Next. Okay, so this is the outlines for personality development. I will talk about introduction, Piaget and Ericsson theory, while the rest will be explained by the next presenter. Next. So my name is Nur Aizata binti Maknasi. So what is personality development? Next. So personality development is the development of the organized pattern of behaviors and attitudes that makes a person distinctive. It occurs by the ongoing interactions of temperament, which is a set of genetically determined traits that determine the child's approach to the world and how the child learns about the world, adaptive patterns related to a child's specific environment, and character, which is a set of emotional, cognitive, and behavioral patterns learned from experience that determine how a person thinks, feels, and behaves. Next. Okay, so our personalities make us unique, but how does personality develop? How exactly do we become who we are today? And can personality ever change? So to answer these questions, many prominent theorists develop theories to describe steps and stages that occur on the road of personality development. So one of them is Piaget's stages of cognitive development. So Piaget's theory asserts that intellectual development is a direct continuation of inborn biological development. That is, the child is born biologically equipped to make a variety of motor response, which provide them with framework for thought process that follow. He also stressed that as children mature mentally, they pass sequentially through 4 major stages of cognitive development. Next. So the stages of the cognitive development are sequential and follow invariant sequence. This means that the child cannot skip or miss or bypass a stage. Piaget suggested that all children journey through the sensory motor, pre-operational, concrete operations, and formal operation stages of development. So during the process of moving through one stage to the next, children's cognitive ability change qualitatively. The first stage of cognitive development is the sensory motor stage, which starts from birth until 2 years and characterized by object permanence, followed by pre-operational stage that starts from 2 to 7 years old, characterized by symbolic thought. The third stage is concrete operational stage between the age of 7 until 11 years old with the goal of logical thought, and lastly, formal operational stage when children age 12 years and beyond, characterized by scientific reasoning. Next. So let's zoom into each of stages. So during sensory motor stage, cognitive activity is based on immediate experience through the senses. So the major intellectual activity here is the interactions of the sense and environment. And then children have not developed a language for labeling experience or symbolizing, hence they're remembering events and ideas. In other words, they see what is happening and feel it, but they have no way of categorizing their experience. Their response are almost completely determined by the situation. For example, a hungry child will literally scream the house down for food. And then during this stage also, a phenomenon known as visual pursuit is manifested. So the child will visually pursue an object relentlessly long after all the children would have lost interest. So this visual pursuit later on develops the capacity of object permanence, in which as children begin to develop intellectually, they understand that when an object disappears from you, it still exists even though they cannot see it. Next. In the pre-operational stage, children begin to think symbolically and learn to use words and pictures to represent objects. According to Piaget, the first limitations of the pre-operational stage is animism, where children attribute living qualities to inanimate objects such as toys. Another limitation is egocentrism, where the child is struggle to see things from the perspective of others. Children during the pre-operational stage also have conservational difficulty, which refers to inability to recognize that something remains the same amount even if its shape change. For example, if you take a lump of clay and divide it into two equal pieces, so one piece of clay is rolled into a compact ball while the other is smashed into a flat pancake shape. So since the flat shape looks larger, the child will likely choose that piece even though the two pieces are exactly in the same size. Next. So in concrete operational stage, as children continue into elementary school, they become able to represent ideas and even more flexibly and logically. Piaget suggested that children during this period, they are less egocentric and begin to understand the concept of conservation, that the amount of liquid in a short white cup is equal to that in a tall skinny glass, for example. And then concrete operational thinking differs from pre-operational in two ways. One is reversibility, or ability to think about the steps of a process in any order, and decentration, where the child can attend two things at once quite purposely. Next. The final cognitive stage among children is the formal operational stage. So Piaget believes that adolescents in this stage are able to formulate hypotheses, deal with abstracts such as mathematical problem, and also able to reason contrary to the fact. Next. Another theory that can explain personality development is Ericsson's theory that based on epigenetic principle. So according to this principle, successful completions of each stage results in healthy personality and acquisitions of basic virtues. Meanwhile, failure to successfully complete a stage can result in reduced ability to complete further stage and therefore a more unhealthy personality. Next. Ericsson maintained that personality develops in 8 stages of psychosocial development from infancy to adulthood. So during each stage, the person experiences a psychosocial crisis which could have a positive or negative outcome for personality development. Let's go one by one. Next. Trust versus mistrust is the first stage in Ericsson's theory of psychosocial development. So this stage begins at birth, continue to approximately 18 months of age. The important event in this stage is feeding, as Ericsson noted that the infant lives through and love with its mouth. Indeed, the mouth forms the basis of its first mode or patterns of behavior. So a baby whose mother can anticipate and respond to its need in a consistent and timely manner despite its oral aggression, we learn to tolerate the inevitable moments of frustrations and deprivations. But if these needs are not consistently met, mistrust, suspicions, and anxiety will develop. Success in this stage will lead to the virtue of hope by developing a sense of trust. The infant can have hope that as new crises arise, there is real possibility that other people will be there as a source of support. Next. Autonomy versus shame and doubt is the second stage, which occurs between the age of 18 months to approximately 3 years. Ericsson believed that toilet training is a vital part of this process, as learning to control one's bodily functions leads to feeling of control and a sense of independence. Other important events include toy preferences and clothing selections. So at this point, children are just starting to gain a little independence. They are starting to perform basic actions on their own and making simple decisions about what they prefer. So by allowing kids to make choices and gain control, parents and caregivers can help children develop a sense of autonomy. But if children are criticized and overly controlled, they become overly dependent upon others, lack self-esteem, and feel a sense of shame and doubt in their abilities. So success in this stage will lead to the virtue of will, which is the belief that children can act with intention, within reason and limits. Next. The third stage, initiative versus skill, takes place during preschool years. Central to this stage is play with other children at school, as it allows them to explore their interpersonal skills through initiating activity. So those who was given opportunity to plan and make up games with others can develop a sense of initiative and feel secure in their ability to lead others and make decisions. However, for kids who fail to develop a sense of initiative, may emerge with a fear of trying new things or guilt. This means that when they do direct efforts towards something, they may feel that they are doing something wrong. Basically, kids with initiative, they will understand that mistakes happen and they just need to try it again. But for children who experience guilt, they will instead interpret mistakes as a sign of personal failure and may be left with a sense that they are bad. Success in this stage will lead to the virtue of purpose, whereby using their own imagination, they create their own purpose in their life. Next. Ericsson's fourth psychosocial crisis involving industry versus inferiority occurs during early school years from approximately age 5 to 13. So at this stage, peer group become a major source of the child's self-esteem. The child now feels the need to win approval by demonstrating specific competencies that are valued by society and begin to develop a sense of pride in their accomplishments. So if they are encouraged and reinforced for their initiative, they begin to feel industrious and feel confident in their ability to achieve goals. But if it is restricted by the parents and teacher, then the child begins to feel inferior, doubting his own abilities, and therefore may not reach his potential. It is true that some failure may be necessary so that the child can develop some modesty. Again, a balance between competence and modesty is necessary. Success in this stage will lead to the virtue of competence. Next. The fifth stage of Ericsson theory is identity versus role confusion, and it occurs during adolescence from about 15 to 21 years old. During adolescence, the transition from childhood to adulthood is most important. Children are becoming more independent and begin to look at the future in terms of career, relationship, families, and so on to fit in the society. So those who receive proper encouragement through personal exploration emerge from this stage with a strong sense of self and feelings of independence and control. However, failure to establish a sense of identity within society can lead to role confusions where the individual not being sure about themselves or their place in society. Completing this stage successfully leads to fidelity, which is described as ability to live by society's standard and expectations. Next. Intimacy versus isolation is the sixth stage of Ericsson's theory. So this stage takes place during young adulthood between age of 21 to 40. So during this stage, the major conflict centers on forming intimate, loving relationship with other people. Ericsson believed that a strong sense of personal identity is important for developing intimate relationships. Studies have demonstrated that those with a poor sense of self tend to have less committed relationships and are more likely to struggle with emotional isolation, loneliness, and depression. Successful resolution of this stage result in the virtue of love, marked by the ability to form lasting, meaningful relationship with other people. Next. The seventh stage, generativity versus stagnation, takes place during middle adulthood. Psychologically, generativity refers to making your mark on the world through creating or nurturing things that will outlast an individual. So we give back to the society by raising our children, being productive at work, and becoming involved in community activities and organizations. So through generativity, we develop a sense of being a part of the bigger picture. But failure to find a way to contribute, causing the people to become stagnant and feel unproductive. So these individuals, they may feel disconnected or uninvolved with their community and with society as a whole. Success in this stage, it will lead to the virtue of care. Next. So the final psychosocial stage, integrity versus despair, occurs during maturity and is focused on reflecting back on life. So at this point, people look back on the events of their life and determine if they are happy with the life that they live or if they regret the things that they did or didn't do. Those who look back on a life they feel was well lived will feel satisfied. Meanwhile, Ericsson believes that if we see our life as unproductive, we will feel guilt about our past or feel that we did not accomplish our life goal, thus become dissatisfied with life and develop despair. Success in this stage will lead to the virtue of wisdom, which enables a person to look back on their life with a sense of closure and completeness and also accept death without fear. Next. This is the summary of the Ericsson psychosocial stages that have been explained just now. You guys carried it after this. So that's all from me. Thank you.
Okay, so I hope everyone can hear me. Bismillahirrahmanirrahim. My name is Amin Hakimi bin Amri, and inshallah, I'll be continuing the presentation with another model of personality known as the Big Five personality traits. Okay, next. So according to the model, there are 5 basic dimensions of personalities, which are openness, conscientiousness, extraversion, or often spelled as extroversion, agreeableness, and neuroticism. So you might find it helpful to use the acronym OCEAN, OCEAN, when trying to remember the Big Five traits. It is important to note that each of the 5 personality factors, it represents a range between 2 extremes. For example, extraversion, it represents a spectrum between extreme extraversion and another extreme, which is introversion. So in the real world, most people will lie somewhere in between the 2 polar ends of each dimension. Okay, next. So the first trait is openness, which features characteristics such as imagination and insight. So people who are high in this trait is very creative. They tend to have a broad range of interests. They are curious about the world and other people, and eager to learn new things and enjoy new experiences. So in simple words, they are more open towards something new and something different. But on the other hand, people low in this trait are often much more traditional. They dislike change and does not enjoy new things and may struggle with abstract thinking. Next. The second trait is conscientiousness. So standard features of the dimension include high levels of thoughtfulness, good impulse control, and goal-directed behavior. So those high in this trait, they tend to be more organized, they spend time preparing, and very good in prioritizing. They will plan ahead, think about how their behavior affects others, and are mindful of details. So, but in contrast, those with low quality of this will tend to procrastinate. They dislike structure and also schedules that already fixed for them. So they do not like kind of rigid schedule for them. Next. So next is a term that I believe very familiar to everyone, which is extraversion, or called as extroversion sometimes, which is characterized by excitability, sociability, talkativeness, assertiveness, and high amounts of emotional expressiveness. So people who are high in extraversion, they are more outgoing. They tend to gain energy in social situations. They enjoy being the center of attention, likes to start conversation, enjoys meeting new people, and being around other people will help them feel energized and excited. People who are low in extraversion or introverted tend to be more reserved and have less energy to expand in social settings. They prefer solitude, finds it difficult to start conversations, and easily exhausted in social settings. Next. So the fourth trait is agreeableness, in which this personality dimension includes attributes such as trust, altruism, kindness, affection, and other pro-social behaviors, which makes them easily likable by others in general. So people who are high in agreeableness, they tend to be more cooperative, enjoys helping and contributing, and cares more about others, while those low in this trait tend to be more competitive and sometimes even can be manipulative also. Okay, next. And last but not least is neuroticism, which is a trait characterized by sadness, moodiness, and emotional instability. So individuals who are high in this trait more likely to experience mood swings, anxiety, irritability, and sadness. They tend to get more stresses, worries about many things, and gets up easily, and have very dramatic shifts in mood. But those low in this trait, they tend to be more stable, emotionally stable, and emotionally resilient. Next. This is the simplified diagram of the Big Five personality and also the high score characteristic and low score characteristics. Okay, next. Okay, next is the brief introduction about a test, psychological test called as Minnesota Multifaceted Personality Inventory, or MMPI. Okay, next. It is a psychological test that assess personality traits and also can be used to can be used to diagnose psychopathology. So it is primarily intended to test people who are suspected of having mental health disorder or other clinical issues. So other than personality traits, it can also detect psychopathology. But other uses can also be used in legal cases, including criminal defense and custody, as well as to screen psychological stability for workers in profession, especially high-risk professions such as pilots, police, and also military. And also can also be used to assess effectiveness of treatment programs. Okay, next. So in general, so MMPI have 10 clinical skills that are used to indicate different psychological conditions. But despite the names given to each scale, they are not a pure measure of the condition, since many conditions have overlapping symptoms. So let's go through the scale one by one. Scale 1 is to check for hypochondriasis, which means the tendency to believe that one has an undiagnosed medical condition. So this scale is used to assess a neurotic concern over bodily functioning. Scale 2 was designed to identify depression characterized by poor morale, lack of hope in the future, and general dissatisfaction. So very high score may indicate depression, while moderate score tends to reveal a general dissatisfaction with one's life. Okay. Scale 3 is used to identify those who display hysteria or physical complaints in stressful situations, where in this scale, usually women, well-educated person, and person that come from high social class will tend to score higher. Next, scale 4 is for psychopathic deviate, which measures social deviation, lack of acceptance, authority, and immorality. Scale 5 is to assess the masculinity or femininity, while scale 6 is to assess paranoid symptoms such as suspiciousness, excessive sensitivity. Next. Scale 7 is to assess psychasthenia, which measures a person's inability to resist specific actions or thoughts. So today, this scale are more reflective of anxiety, depression, and obsessive compulsive disorder. Scale 8, 9, and 10 is to measure for schizophrenia, hypomania, and social introversion, respectively. Okay, next. So this is the summary of 10 clinical scales in MMPI, and also how do we interpret high score. Okay, next. Okay, another part of MMPI is the validity scale. So it contains simply 4 validity scales that is designed to measure a person's test-taking attitude and also approach to the test. So the first one is the lie scale, L scale. It is intended to identify individuals who are deliberately trying to avoid answering the test honestly and in a frank manner. Then next is the F scale. Even though the F doesn't stand for anything, sometimes referred as infrequency or frequency scale, but it is intended to detect unusual or atypical ways of answering the test item. For example, like if a person were to randomly fill out the test. Okay, another scale is back F scale. It is the same thing. It measures the same issues as the F scale, except only during the last half of the test. And lastly is the K scale, which is designed to identify psychopathology in people who otherwise would have profiles within the normal range. So it measures self-control, measures family and interpersonal relationship, and people who score highly in this K scale are often seen as being defensive. Okay, next. I think that's all from me. We can proceed to the next presenter to continue the presentation.
Bismillah. I will be the next presenter. My name is Nsd Azmi binti Kamarozi, matric number 1715598. My two other colleagues and I will be talking about personality disorder. Next. So from Kaplan and Sadok and DSM-5, personality disorder is defined as an individual pattern of behavior and inner experiences that deviated significantly from the individual's culture standards and is rigidly pervasive. So it is quite common and a chronic disorder in which approximately there is 15% of all psychiatric patients actually have personality disorder. So it also has an onset in adolescence or early adulthood, and leads to unhappiness and impairment, as well as and manifests in at least two of the four following areas, which is cognition, affectivity, interpersonal function, or impulse control. So it involves more than one domain lah. Next. So the definition that I already explained before is taken from the Kaplan and Sadok, that is referred from DSM-5. So in DSM-5, already introduced a general set of criteria for personality disorder, in which same as definition earlier. If present, the clinician should determine which of the 10 specific disorder that we will discuss later that will match the patient condition. So we have to take note that the person presentation may meet the criteria of more than one disorder. And when a patient have more than one personality disorder, clinician, the doctors, the secretaries should diagnose each one of them. And as I said earlier, the personality disorder is a stable, which means involve a long duration of time, as in criteria D. As a general rule, the personality disorder tend to lessen in severity or burn out with age. So during follow-up, many of the patients will no longer meet full diagnostic criteria. So the symptoms, however, the symptoms may remain impairing for the patient. As why? Because of the personality disorder is actually appearing at the formative period of the patient life, in which at that time the patient are completing the education, marrying, starting a family, and as well as establish a career. So it quite impaired to the patient, affected to the patient. So even with the psychotherapy and pharmacological therapy, even with the some improvement, most of the patient with personality disorder will never catch up educationally, socially, or economically with their peers. So in criteria E and F, the rule out criteria, it is meant to rule out other potential causes for the personality disturbance. Next. The etiology, we have genetic, biological factors, environmental, and social factors. So for the genetic, the best evidence is from the investigation of more than 15,000 pairs of twins in the United States that show the concordance for personality disorder among monozygotic twins was several times compared to dizygotic twins. So this show that there is a genetic factor here. And then for the biological factor, the study has shown that the person with high level testosterone, 17 estradiol and estrogen, exhibit a impulsive trait, which is an acting without planning. So this is tally with non-human study where the androgen increase the likelihood of the aggression and sexual behavior in the non-human study, in non-human. Plus with the Nsd results are abnormal seen in patients with borderline personality disorder who have depressive symptoms. So we also have cortisol level abnormal. And next is low level of platelet monoamine oxidase is associated with, in some patients with schizotypal disorder, where it also shown in some study that it is associated with the activity and sociability in monkey. So for brief introduction to the schizotypal that we will discuss more later, it is a strange, it is a striking, oddly strange behavior. Yeah, it is odd behavior. Next. Next is a smooth pursuit eye movement. For this factor, it more shown a role of inheritance, where the psychedelic jumpy eye movement, it is associated with the introvert, low self-esteem, and tend to withdraw and who have schizotypal personality disorder. And for the neurotransmitter like endorphin, 5-HIAA, serotonin, and dopamine also have a role in development of personality disorder. And lastly, the slow wave activity in ECG also shown to be associated with antisocial and borderline personality disorder. Other than what I have shown here, genetic and biological factor, we also have environmental and social factor that contribute to the personality disorder. However, I will not shown here because just a simple brief about that. For the environmental factor, for example, like culture factors, family, religion, school, and jobs. While for the social factor, for those who are experiencing abuse, mistreatment, and family dysfunction. Next. So, personality disorder subtype was being classified in DSM-5 into 3 clusters. Throughout the 5 DSM we have, they have actually tried to define and classify each subtype. But starting DSM-3, the concept cluster is introduced, in which the disorder type were grouped with by their predominant symptom patterns. Like for example, cluster A, the patient appear to be odd and eccentric, and B, while B is dramatic, emotional, and erratic, and C, anxious and fearful. All of this will be discussed later. Next. First, we go to the first personality disorder in cluster A. Next. So, person with paranoid personality disorder are characterized by long-standing suspiciousness and mistrust of the person in general. They in response to the paranoid belief, they are often appear hostile, irritable, avoidant, and angry. So this person often they are often usually refuse responsibility for their own feeling and assign responsibility to the others, and usually found in bigots, which is a person who are internally devoted to his or her own opinion, and really prejudiced to the others, like the racial or ethnic group hatred and intolerance. For the injustice collector, like a grudge collector, someone who really cannot forget or cannot forgive everything. And then for the litigious pathological jealous spouses, and litigious cranks, like someone who really like to sue everything that doesn't come in their way. And next, for the epidemiology, the data suggests that the paranoid personality disorder comprise of 2 to 4% of the general population, and the relative of patient with schizophrenia shows a higher incidence of paranoid personality disorder. And in fact, the research suggests that paranoid personality disorder lies within the schizophrenia spectrum. And it is higher prevalence in men compared to women, and higher in minority groups like immigrant and deaf person. For the cause and prognosis, in others person, it is the paranoid trait is actually give away for the reaction formation that we learned earlier. It is actually a defense mechanism. So it give away for reaction formation for us to give appropriate consent about the morality as we are measured. But with the patient, with the paranoid personality disorder, we'll have a lifelong problems that involve in their working and living with others, especially in occupational and marital problem. And in some patient also, it is lifelong, but in others person, it can be predisposed to schizophrenia too. Next. For the clinical features, the hallmark here is the excessive suspiciousness and distrust. Next, it can appear in early adulthood. The patient like to dispute without any justification. They are pathologically jealous, often question fidelity, and they are proud of themselves for being rational and objective, and they are lack of warmth and pay close attention to power and rank. Next. So on the psychiatric examination, the patient with paranoid personality disorder may be formal in manner and act baffled about having to seek psychiatric help. They have muscular tension, they are unable to relax, then always scan the environment for the clues to help them to actually find an evidence to mistrust. And then the patient manner also appear to be humorless and serious. Their speech is goal-directed and logical, and their evidence and their thought of content shows evidence of projection, prejudice, and occasional ideas of reference. Next. Next. Okay, this is an illustration. You can go through later. Next. So the clinical features and psychiatric examination that I already explained before is tally and stated in the DSM-5 criteria. Next slide. So paranoid personality disorder is like I already explained before. It is indicated by 4 or more of the following. Maybe my internet is lagging for DSM-5 tadi. Paranoid personality disorder is indicated by 4 or more of the following. And then the criteria stated that it shouldn't occur exclusively during the course of the other psychotic disorder and shouldn't be attributed to the other medical condition. Next. For the internet lambat. Next slide for the DDX, differential diagnosis. Okay, differential diagnosis. First, differential diagnosis is delusional disorder. So it's different from the paranoid personality disorder by the absence of the fixed delusion in the delusion disorder. For the paranoid schizophrenia, it's different with the it differ with the absence of hallucination or former thought of disorder. And then for the borderline personality disorder, it can be distinguished by the paranoid by paranoid ni it's rarely it incapable to overly involve in social because of the mistrust issue. So it's different from the borderline personality. Next is antisocial, where the paranoid doesn't have a history of antisocial behavior like antisocial that we will discuss by my colleagues after this. And then for the schizoid personality, is schizoid ni it is a withdrawn and aloof behavior, so it doesn't have a paranoid ideation. So yeah. And then for the treatment, like we already learned earlier about the psychotherapy, there are a lot of psychotherapy and the form of the psychotherapy, individual, group, family, and the couple. But in this presentation, I will only briefly explain about the how to approach to the patient. So we have to be straightforward to the patient. The therapist should be honest to the patient rather than defensive. So when the patient attacking them with mistrust issue, we have to be honest rather than give an excuse. And for the therapist also shouldn't be overly don't overly warm, and be professional to the patient during the individual psychotherapy, and not be overzealous, not to be eager in the interpretation that involve deep feeling of the patient because they have mistrust issue. So we must not too eager to them. And then deal realistically and gently with the delusional accusation, and never offer to take control unless they're willing to do so, because they didn't want to help. They didn't want help from us. They didn't want help from those who they think are weaker than them. So we have to let them think we are strong than them before they ask for the help. So this paranoid personality disorder also do not do well in group, because although it is useful for social skill, but they can't really tolerate with the intrusiveness of the behavior therapy, which invading the personal space. And then for pharmacotherapy, we have anti-anxiety, antipsychotic for the anxiety and psychotic symptom. Next. Okay, next we go to the schizoid. Next. Schizoid personality disorder is characterized by a lifelong pattern of social withdrawal. Okay. So they are characterized by social withdrawal, and the patient are often seen as eccentric, odd, isolated, and lonely, and they are discomfort with the human interaction. So they will have difficulty achieving intimacy or developing emotionally meaningful relationships. And the prevalence are not clearly established, but they may affect 5% of the general population, and male are more prevalent than women, and usually it appears in early childhood or adolescent, which is long lasting but not necessarily lifelong. Next. For the clinical features, the person with schizoid personality disorder seems to be cold and aloof. They display a remote reserve and show no involvement in everyday events and concerns of the others. They appear quite quiet, distant, and seclusive, and unsociable, and have little longing for emotional ties. And they will be the last person to be aware of the changes in the populations. And then they also have usually have solitary interest, and usually success in non-competitive and lonely jobs. And in terms of sexual life, they have a sexual life in fantasy actually, and they may appear to have a delayed matured sexuality, where the man may not be married, or woman may basically agree to marry to the aggressive man who want to marry them. And next, they usually have interest in non-human matter, where the life where they usually have interest in non-human matter that they will have problem with in a lifelong inability to express the feelings. And usually they are more invest in non-human interests like mathematics, astronomy, animals that no personal involvement. And they also appear to be self-absorbed and lost in daydream. Next. Okay. On psychiatric examination, patient with schizoid personality disorder may appear ill at ease. They rarely tolerate eye contact, constricted, aloof, and inappropriate serious. But the experienced and sensitive therapists may recognize fear from them because of the from the social withdrawal. And then the patient may find it difficult to be lighthearted, entertained, because the effort for the humor may seem be off marks, and their speech is goal directed. Short answer avoid spontaneous conversation, and occasionally they will use unusual figures of pictures, like metaphors, and inanimate objects or metaphysical constructs. And with that, this type of personality disorder have unwarranted sense of intimacy with persons that they do not know well. Next. Sorry for the delay. Okay, so what I already explained before, already is tally with the DSM-5 criteria. So schizoid personality disorder is indicated if the patient have 4 or more of the following that I already explained. And same as before, criteria B, it shouldn't be occur exclusively during psychotic disorder or any medicational condition. Next. For the differential diagnosis, first is schizophrenia, delusional disorder, and affective disorder with psychotic features is different from the schizoid personality by the positive psychotic symptoms such as delusion and hallucination. For the slide memang tak gerak ke? Aish. For the paranoid personality disorder, it shared many traits with the schizoid. Oh, okay. Thank you, Shah. Okay, for the differential diagnosis, first we have schizophrenia, delusional disorder, and affective disorder that different from the schizoid is by the psychotic symptom. While for the paranoid personality disorder is different from the schizoid by the social engagement. So paranoid is has no issue with social engagement, while the schizoid has social withdrawal. And then for the obsessive, compulsive, and avoidant personality, it actually will be best described by the next presenter, I think. But basically, it's different from the schizoid. Is by the emotionally, it is emotionally constricted, where they experience loneliness as dysphoric, where tidak apalah. Next presenter terang lah. Next is schizotypal. Is different from the schizoid personality disorder, which schizotypal is more similar to the schizophrenia, but basically it's same as schizophrenia but different in terms of the absence of the psychosis symptom. Next is autistic disorder and Asperger syndrome. It is different by the where schizoid personality disorder is more severe impaired social interaction and with the stereotypical behavior and interest than in those of two disorder. Next is the treatment for the psychotherapy. It is actually similar to the paranoid personality disorder, but we have to take note that schizoid personality disorder doesn't have problem with the trust. They only have problem with the social withdrawal. So as the trust develop, the patient may reveal a lot of things to us, including their fantasies, imaginary friends, and even become friends with the therapist. So they don't have trust issue here. So the group therapy setting will be work well with them, as but they may appear silent for long periods, but they can help in social skill themselves. Okay. For pharmacotherapy, we have antipsychotic, antidepressant, and psychostimulant, teratogenic agent, and benzodiazepine that help in anxiety and psychotic symptoms. Next. Okay, for the last subtype for the cluster A, schizotypal. Next. So schizotypal personality disorder is defined as a pattern of peculiar behavior or speech and thinking and unusual perceptual experience. So this person have strikingly odd and strange behavior, but they don't have a psychotic symptom. They psychotic. Okay. So they also have magical thinking, ideas of reference, illusion, and derealization. And they comprise of 3% of general population. The sex ratio is unknown, but frequently diagnosed in female with fragile X syndrome. But in DSM-5, it show that there is a slight more common in males. And then there is actually evidence of the biological relative that involved in the schizotypal because it involved in schizophrenia syndrome disorder. Okay, for the cause and prognosis, like I said earlier, the schizotypal is a premorbid personality for the patient with schizophrenia. So some, however, maintain a stable schizotypal type of personality throughout their life and marry and works, despite the oddities. However, there is a downside for that, where a study shows that there are 10% of the schizotypal personality disorder will eventually commit suicide because of their odd thinking. Next. For the clinical features, patient with schizotypal personality disorder will exhibit disturbed thinking and communication. So their speech also is distinctive, peculiar, and have meaning only to them, and often need interpretation. And next is this patient also may have superstitious or claim power for the clairvoyance, and may believe that they have other special powers of thought and insights. And even their inner world may fill with the vivid imaginary relationship and childlike fears and fantasies. And many of the schizotypal patient have also borderline personality disorder. And then they also have poor interpersonal relationship that they may act inappropriately with the others. So they usually appear isolated and have little friends. Next. This is the pictures you can go through later. Next. For the differential diagnosis, in the DSM-5, the schizotypal disorder, personality disorder, is further defined as pervasive pattern of social and interpersonal deficit marked by the acute discomfort and with the reduced capacity for the close relationships. And it's usually beginning by the early adulthood, and it is indicated by 4 or more of the following that I already explained earlier. So same as before, it shouldn't occur exclusively during the psychotic disorder and medical condition. Next. For the differential diagnosis, okay, first is the schizo and avoidant personality is different from the schizotypal by their oddity in behavior, thinking, perception, and even the communication between the friends. And then and schizotypal personality disorder also maybe have a family history of the schizophrenia. And next is but how about the schizophrenia? It's different from the schizotypal, like I said earlier, by the absence of the psychotic features. And then for the borderline personality disorder, they may have meet both of the personality disorder criteria. And then for the paranoid personality disorder, it's different by the paranoid is mistrust, so it's different. They paranoid disorder have trust issue, while the schizotypal is oddly thinking. Okay, for the treatment, psychotherapy, principle of the treatment for the schizotypal, it is not differ from the other two psychotherapy, but the therapists must have deal with sensitively and professionally with the schizotypal patient. Why? Because they actually have a peculiar pattern of thinking, and they may involve in some cults, strange religious practice and occults. So the therapist must not radical their activities and thinking. So we must not be judgmental about them. And then for the pharmacotherapy, we have antipsychotic medication and antidepressant. Okay, next. Okay, for some recap, next. Some recap. So cluster A, the patient may appear odd and eccentric, which is different from the others. We have paranoid, schizo, and schizotypal. Paranoid is the patient have trust issues. Schizo when the patient have social withdrawal. Schizotypal when the patient have odd, strange thinking that involve magical thinking without psychotic features. Okay, we proceed to cluster B.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Simon with the metric card number 1711567. So I will continue the presentation by talking about the cluster B personality disorders, which is characterized by dramatic, emotional, or impulsive behaviors. So under cluster B personality disorders, they are antisocial, borderline, histrionic, and narcissistic. Sekejap hang pula. Okay, sorry for the delay. Okay, so let's continue. Okay, next. Okay, so we first move on with the antisocial personality disorder. Okay, so antisocial personality disorder is defined as a pattern of disregard for and violation of the right of others. It means that patients with this type of disorder, they tend not to care for others or for others' right. Next. Okay, so for the epidemiology, so it is more common in male rather than female, and it is more common in low socioeconomic status and poor urban areas. According to a study, there is a highest prevalence, which is more than 70%, among males with alcohol disorders, substance abuse, and from the prison population. Next. So the cause and prognosis for this type of disorder. So antisocial personality disorder, it is a chronic, but however, it will become less evident as the individual grows older, particularly by the fourth decade of life. And among the complications include dysphoria, tension, low tolerance for boredom, depressed mood, premature violent death. Next. Okay. So for the Dynastic Criteria for this type of personality disorder, so under criteria A, this pattern, this personality should be occur since the age of 15 years old and with 3 or more signs or symptoms. First, failure to conform or to comply to the social norms. Second, deceitfulness, for example, repeated lying. Third, impulsivity. Fourth, irritability and aggressiveness. Fifth, reckless. Sixth, consistent irresponsibility. And seventh, the lack of remorse. Next. For criteria B, so supposedly the individual should be at least age 18 years old. Only then we can diagnose the person to have antisocial personality disorder. And also there should be evidence of conduct disorder with onset before the age of 15 years old. And the last one is the antisocial behavior should not occur exclusively during the course of schizophrenia or bipolar disorder. Next. Okay. Patient with antisocial personality disorder, they might have some misconduct during their childhood history. For example, like lying, truancy, running away from home, fighting, and substance abuse. And among common adulthood events is promiscuity, spousal abuse, child abuse, and drunk driving. Okay, next. So differential diagnosis first is substance use disorders. Second, schizophrenia and bipolar disorder. But however, we cannot diagnose antisocial personality disorder during the course of schizophrenia and bipolar disorder. And third, we should also exclude other personality disorders because some of the personality disorders may share the same features or characteristics with antisocial personality behavior. And also, we need to know also there is some characteristics that can distinguish between antisocial personality behavior and other personality disorders. And the fourth is criminal behavior, but not associated with any personality disorder. Next. Okay, so among the management for psychotherapy, for this type of personality disorder, so first we go on with the psychotherapy where we have contingent management and other reward-based intervention. However, contingency management means that it is a therapy where if the patient able to achieve the target of the treatment, then he or she will be rewarded. And according to a study, this type of psychotherapy is actually patient respond more better rather than the cognitive behavioral therapy. Okay, so for pharmacotherapy, basically we want to treat the symptoms like rage, aggression, mood instability. So we give mood stabilizer, antipsychotic, and SSRI. Okay, next. Okay, Next is borderline personality disorder. Next. It is defined as a pattern of instability of the interpersonal relationship, self-image, affects, and also marked impulsivity. So patients with borderline personality disorder, they always appear to be in state of crisis and having frequent mood swings. Next. So under epidemiology, so it is more common in female and more common in younger than in older population. And it is 5 times more common among first degree biological relatives. And under the patient with a borderline personality disorder usually have a history of physical and sexual abuse, neglect, hostile conduct, and early parental loss or separation. For the cause and prognosis, it is commonly chronic instability in early adulthood with episode of severe affective and impulsive discontrol. And they also have a higher risk of suicide in young adult years, but however, it will gradually reduce when the age advance. And in the fourth and fifth decades, as they age, they tend to attain greater stability in their relationships and functioning. Next. So for the Dynastic Criteria, so there should be a 5 or more symptom of sign. First, the patient will tend to have frantic efforts. Frantic means the patient it is an effort that is in disorganized or in a hurried way to avoid any real or imagined embodiment. Second, it is a pattern of a patient will really have a unstable and intense interpersonal relationship. Third, having identity disturbance. Fourth, impulsivity. Next. Okay. Fifth, they will have a recurrent suicidal behavior or self-mutilating behavior. Means he or she will try to self-harm him or herself. Six, affective instability. Affective instability due to marked reactivity of mood. And 7, they have a chronic feeling of emptiness. And 8, they will have a inappropriate and intense anger or difficulty in controlling their anger. And 9, they have a stress-related paranoid ideation or severe dissociative symptom. Next. Next. Okay, so these are 9 symptoms of borderline personality disorder. It is the same as in Dynastic Criteria, where patients have unclear or shifting self-image, unstable interpersonal relationship, mood swings, impulsive and self-destructive behavior, fear of rejection or abandonment, self-harm and suicidal tendency, feeling of emptiness, and loss of touch with reality. Next. Okay, so for differential diagnosis, first is depressive and bipolar disorder. It is usually it is borderline personality disorder often co-occurs with depressive and bipolar disorder, and we should also exclude other personality disorder and personality change due to another medical condition, substance use disorder, and fifth is identity problem. Identity problems here it refers to identity concern related to the development phase, for example, adolescent, and however, it is not qualified to be counted as mental disorder. Next. Okay. So for the treatment, under psychotherapy, we have dialectical behavioral therapy, mentalization-based therapy, and transference focus therapy. So I will not explain detail regarding these 3 psychotherapy because it is a little bit complex and detailed. But dialectical behavioral therapy, it is type of cognitive behavioral therapy. And metallization-based therapy. Okay, and metallization-based therapy is it is actually based on a theory that it is actually metallization-based therapy. It is a social construct to allow a person to be attentive to his or her mental state. It is based on the theory that in patients with borderline personality disorder, they have difficulty in regulating their emotion and managing their impulsivity. So by correcting their mental state, so we are able to reduce the symptom. And lastly, the transference focused psychotherapy. It is a modified form of psychodynamic psychotherapy, where it helps the patient to develop positive self-regard. Okay. So for the pharmacotherapy, as usual, we need to give antipsychotic, antidepressant, anticonvulsants, and SSRI just to control the symptom. But however, it is important to avoid giving benzodiazepine because it is first because it can there is a risk of drug abuse, and second because it can worsen the symptom. Okay, next. Next is histrionic personality disorder. Next. So it is defined as a pattern of excessive emotionality and attention seeking. Next. Epidemiology, it is about 2% in general population, and it is equally frequent among males and females. Cause and prognosis, since they are sensation seekers or attention seekers, they may get into trouble with law, abuse substances, and act promiscuously. However, with age, they might show fewer symptoms. Next. So the Dynastic Criteria it is indicated by 5 or more of the following. First, patient is uncomfortable in situation where he or she is not the center of attention, since they are attention seeker. Second is their interaction with others is usually inappropriate, sexually seductive or provocative behavior. They tend to display rapidly shifting and shallow expression of emotion, and they consistently use physical appearance to draw attention to self. They have a style of speech that is impressionistic but lack in detail, show self-dramatization and exaggerated expression of emotion. Is suggestible, means it is easily influenced by others or circumstances, and they tend to consider relationship to be more intimate than they actually are. Next. Okay, so these are clinical features. Maybe you can do it later. Basically, it's the same as the Dynastic Criteria I mentioned before. Next. So differential diagnosis, as usual, is need to exclude other personality disorders, personality change due to other medical condition, and substance use disorders. Next. Okay, treatment. Basically, we have psychotherapy. So basically, psychoanalytically oriented psychotherapy, and pharmacotherapy. Just we give antidepressant, anti-anxiety, and antipsychotic to control the symptoms. Okay, next. Okay, so the last personality under cluster B is narcissistic personality disorder. Next. So it is a pattern of grandiosity that need for admiration but lack of empathy. Next. So epidemiology, it is common in male rather than female, and prevalence it is less than 1% in general population and about 2% to 6% in clinical population. For the cause and prognosis, it is chronic and difficult to treat. However, the symptoms tend to diminish by age of 40 years, and the impairment is frequently severe, and may include marital and interpersonal relationship in general. The narcissistic traits may be particularly common in the adolescent. However, it does not necessarily indicate that the individual will go on to have the narcissistic personality disorder in the future. Next. So for the diagnostic criteria, okay, so it is indicated by 5 or more of the following. First, patient has a grandiose sense of self-importance, which means they expect to be recognized as superior. Okay, then second is preoccupied with fantasies of unlimited success, power, beauty. Third is belief that he or she is special and unique. And fourth, they require excessive admiration. Next. Fifth, they has a sense of entitlement, means they expect others to give him a favorable treatment. However, he or she didn't contribute anything, or maybe a little. 6 is interpersonally exploitive. 7, lack of empathy, and they often envious of others, or they may believe others are envious of him or her, and they show arrogant, haughty behavior and attitudes. Next. Okay, so these are the clinical features. And next. So differential diagnosis, other personality disorder or traits, mania or hypomania, because of they share the same characteristic which both exhibit grandiosity. However, it is important to note that in mania and hypomania, the grandiosity is episodic cause and usually associated with euphoria and functional impairment. And third is substance use disorder. Okay, next. Okay, lastly, the treatment under psychotherapy, we have the psychoanalytic approach and group therapy. Pharmacotherapy, we have the mood stabilizers and antidepressants. Next. So I think that's all from me. Pass on to the last presenter. Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Ninur Awati Najah. Matric number 1717356. I will continue with cluster C, personality disorder. Okay. Compared to cluster A and cluster B, cluster C is described as anxious and fearful personality type of disorder. And as you can see here, there's an area of overlap, meaning that an individual can have one or more of type of personality disorder from different clusters. Okay, under cluster C, there are avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. For avoidant personality disorder, the individual had extreme sensitivity towards rejection and causing them to be reluctant to engage socially. So it may lead to socially withdrawn lives. They are shy but they are not asocial. And then compared to schizoid personality disorder, they show a great desire for companionship. They want to be in a relationship, but they need an unusually strong guarantee of acceptance. And because of this, they are commonly referred to as having an inferiority complex. For epidemiology, it accounts for about 2 to 3% of general population, and it has equal distribution among men and women. For the clinical features, the hallmark is they are hypersensitive towards rejection by others, and because of this, they are afraid to engage socially because they fear of rejection. And then third, they are also anxious and preoccupied with social evaluation. This meaning that they view people's comment as humiliating, as ridiculing, and as a criticism. And they are also have a timid and low self-esteem. For the diagnostic criteria from the DSM-5, avoidant personality disorder is a pervasive pattern of social inhibition, feeling of inadequacy, hypersensitivity to negative evaluation, beginning by early childhood and indicated by 4 or more of the following. First, as I said before, they avoid occupational activities because they're afraid of rejection, criticism, and disapproval. And second, they don't want to get involved of people unless there are certain people like them. And third, they show restraint within intimate relationship because they are fear of shame or ridicule. Fourth, they are preoccupied with being criticized. Fifth, they feel inadequate, view themselves as socially inept, personally unappealing, and inferior to others. And lastly, they are reluctant to take personal risks because they may prove embarrassing. Okay, for the differential diagnosis, first is schizoid personality disorder, borderline personality disorder, histrionic, and dependent personality disorder. For cause and prognosis, some of them may function in a protected environment, meaning they marry, they have children, but they subject to depression, anxiety, and anger. For treatment, the main treatment is psychotherapy, which include group therapy and also assertiveness therapy to increase their self-esteem. Pharmacotherapy is only given when patient had symptoms of anxiety or depression, and we can give beta-adrenergic antagonist or serotonergic agent. Okay, for dependent personality disorder, it is a pattern of relying excessively on others for emotional support and making everyday decisions. These people are very dependent of other person. Okay, for epidemiology, it accounts for about 0.5% of general population. It is more common in women, and it is found that people with chronic physical illness in childhood is more susceptible to develop this personality disorder. And then for clinical features, first, they cannot make decisions without an excessive amount of advice and assurance from others. They need someone to be responsible for their decision. And then second, they are difficult to persevere at tasks when they are alone, but finds it very easy to perform for someone else. And then third, pessimism. They are very pessimist, thinking that they always had thought like, I cannot do this, this is not going to work. So they have a very high amount of self-doubt. And passivity. Passivity means that they accept everything that is suggested to them. Anything people are saying, there's no resistance because they're afraid of being left to take care of themselves. And because of these features, usually people with dependent personality disorder can be a victim of abusive relationship because they depends on the abuser and they feel that they cannot survive without the abuser. And they also have a long-term relationship with one person rather than a series of persons whom they are depends on. Okay, for the Dynastic Criteria, is described as a pervasive and excessive need to be taken care of and leads to submissive and clinging behavior and fear aspiration, indicated by 5 or more of the following. First, difficult to make everyday decision, needs others to assume responsibility for their life. Third, difficult expressing disagreement. Fourth, difficult initiating project on their own. Fifth, go to excessive length to obtain support from others. Sixth, feel uncomfortable or helpless when alone. 7, they seek another relationship as soon as close relationship ends. And lastly, they are very preoccupied with fear of being left to take care of themselves. For differential diagnosis, first is histrionic personality disorder, borderline personality disorder, and agoraphobia. But agoraphobia had higher level of anxiety and even a panic attack. For the cause of prognosis, patient with dependent personality disorder usually had impact occupational functioning and their social relationship limited to those who they can depend on. So they are at risk of major depressive disorder if they lose the person they depend on. However, with treatment and support, the prognosis is favorable. So first line is psychotherapy that is often successful. And lastly, pharmacotherapy when it's associated with anxiety and depression. Okay, lastly is obsessive compulsive personality disorder, OCPD. So this are a chronic maladaptive pattern of excessive perfectionism, preoccupied with orderliness and detail, and the need of control of one's emotion and environment, particularly in the area of interpersonal functioning. For epidemiology, 2 to 8, it accounts for about 2 to 8% of prevalence in general population. It's more commonly in men, and it is most commonly seen in older sibling, people with first degree relative with OCPD, and people with background of harsh discipline. So according to DSM-5, it is described as people with orderliness, parsimony, meaning that they are stingy, and then obstinacy, they are very stubbornly adhered to their opinion. So for clinical features, they are very preoccupied with orderliness, neatness, rules, regulation, and achievement of perfection. So they lack of flexibility and intolerance towards others. So because of this, they have limited interpersonal skills. So they are the types of people who are very formal, serious, lack of sense of humor, unable to compromise, and insist that others submit to their needs. And anything or anyone that threatens their stability or their routine can precipitate anxiety in themselves. Okay, for diagnostic criteria in the DSM-5, first is preoccupied with details, rules, list, orders, schedules, and they are very perfectionist, devoted to work and productivity to the extent that they ignore leisure activities and ignore friendships. They are very inflexible. They cannot discard worn out or worthless objects, and they don't want to work with others unless other people submit to their way of doing things. And then 7, they view money as something to be hoarded for future catastrophe. And lastly, they are very rigid and very stubborn. For differential diagnosis is OCD, Obsessive Compulsive Disorder, and OCPD you also can coexist with delusional disorder. For cause of prognosis, it is variable and unpredictable. Some people grow into a warm, open, and loving adults, but some can develop schizophrenia or later MDD. And although they have a stable marriage and occupational adequacy, but they have a few friends, and depressive disorder are common among them. And treatment include first psychotherapy and pharmacotherapy, but there's a debate in the pharmacotherapy because this drug is known to reduce symptoms of OCD, but they have unknown use in OCPD. Okay, for lastly, it is important to differentiate between OCD and OCPD because in OCD, there is a true obsession and compulsion, meaning that, for example, compulsion is behavior that they think they must do to reduce their anxiety. For example, when someone is obsessed with the germs on their hand, they think that they always have to wash their hands to remove the germs. Or someone who is obsessed with the door lock need to always check on the door. But in OCPD, it is a pervasive pattern of behavior. It preoccupied with orderliness and perfectionism. It does not have an absolute obsession. And then in OCD patient, they have an insight, meaning that they are aware of their obsession as something irrational and problematic. And because of this, it is associated with guilt if their obsession is inconvenient to somebody else. But in OCPD, they are lack of insight because they do not think their behavior is problematic and it is not associated with guilt. And for OCD, it is the ego dystonic, and for OCPD, it is ego syntonic. Okay, that's all from us. Thank you.
All right, thank you very much, presenters. I'm impressed. Very good, excellent presentation. Okay, so let's discuss about what your friends have presented. I hope you've all paid attention. It was long, but interesting, very much detail. All right, so we can see that even from early on, we can, such as the presentation on personality and also personality disorders generally, and also Big Five and MMPI, we can relate it with ourselves, right? Even with the disorder, sometimes some of them we have some of the traits, or our family members or our friends, people that we can see, we know, that we see in, that we can relate to in our everyday lives. It can be artists, it can be some prime minister's wives, or it can be anyone around us. Having said that, though, let's try to look at personality very close to our hearts. That is about our own personality. Yeah, like your friend has presented just now about Big Five. He presented very nicely on the 5 traits of Big Five. So we can see that personality is not like either or. It's not like either you're introvert or you're an extrovert. You can fall in between, and it's not that obvious. Many people fall in between. The most obvious, or people would describe you as an extrovert or introvert, is when you have very high scores. You have very high score of conscientiousness or agreeableness, for example. So people would probably describe you as a perfectionist if you have high conscientiousness, and if you have very low conscientiousness, people probably describe you as lazy. Okay, whatever it is, it's something that we have. Yeah, it's something that that are unique within us. It's at what age do personality get stable? What age?
Teenagers.
Yeah, what specific age? True. It's between young adult and teenager, right?
Adolescent.
Adolescent. Okay. What age? What age does can we start
20.
to
18
huh? 18, exactly. 18 is usually the cutoff point for most of the diagnosis for personality disorders, because personality gets stable at 18. Mostly so, kalau Ocean ni pun at Big Five kan, disorder pun selalunya tak jauh beza lah daripada bila kita start 18 tu. Tak banyak beza sangat. Kalau kita memang orang yang macam laid back, lewat, kalau dah nak dekat deadline, when deadline becomes nearer, then we'll get panicky, anxious, the adrenaline starts pumping up kan, really you start doing things. But some people, even when they got the work, they already start working, and probably 1 or 2 weeks even before the deadline, they've already got their assignment written up. But you, 1 day before, only then you get yourself working on. Can before that, there's nothing, no motivation. You're probably very low on conscientiousness, and the other person who has been finishing their work earlier on is high on conscientiousness. So though these are very unique personalities, we need to be aware which one of it represents us. I mean, where do we fall in each of these? Yeah, like extroversion, where do we fall? Neuroticism, do we get really panicky, really anxious, really stressed up over things, over exams, over some trivial problems? Sometimes you get really panicky, really nervous. Can some other people will just relax, nothing happens, but the same event that is happening. So it's not just about the way we perceive things, but it's also about the makeup of our brain. Personality gets stable. It's based on nature and nurture as well. Yeah, what you've observed in your life. At the same time, what's the biological makeup that you're born with, that you got from your parents, kan? Jadi, when the gap is high, like when you have a roommate who is very laid back, and when you are like a perfectionist, very much arranged and neat, there will be conflict. The higher the gap, the more the conflict. Therefore, it's very important for you to be able to recognize that I have anger within me, because my personality and my roommate is very much different. So I have to learn to accept that she is that way. And she has to learn to accept that I am this way, and therefore you move along the spectrum. The very perfectionist one, the very high in trait, tends to be lesser in higher score, and the very laid back one tends to be more conscious of where she puts things, of where of how she arranges the slippers, of how she does things, because she knows that the roommate is quite neat and whatnot. So you need to learn to move along the spectrum. You can never go on the other end. You can never move from an introvert to an extrovert. It's just your own unique personality of who you are. And it doesn't have to do with kindness. None of it has anything to do with agreeableness, maybe, but it doesn't mean that you're not kind if you're low in agreeableness. It's just that you're just suspicious of others, maybe because you've been trod on, maybe you've had abuse before, many people put you down, therefore you're quite paranoid of other people. So there's no right and wrong, it's just you. Okay, it's just your own unique personality and your friends' personality, your roommate's personality. So it's very near to us. Do you have anything to say about this? Any questions about Big Five? Can you relate to yourself?
Yes.
Kan? Okay, jadi
Doctor, is it similar with identity crisis?
Identity crisis. I'm not quite familiar with that term. It's a very layman term that we don't really use in psychology. We usually would associate that with adolescent, kan? Usually young people, that adolescent ni.
With hormonal imbalance.
Yeah. Sorry again.
Those who have somewhat hormonal imbalance that try to look themselves.
Yeah. Maybe during that time, it's when you're still growing, you're still moving towards forming an identity. Yeah, during adolescence, we're still trying to form an identity. Who are the friends that you like? Who are the people that you want to hang out with? Kind of like still finding your way. But when you've gotten at a stable at 18, then you're kind of like stable in your personality, not so much because you can imagine yourself maybe when you were younger, you were more cheerful, for example, more outgoing. Then when you were in secondary school, you were more quiet, more thoughtful, more before you say something. It may be different, but when you get towards 18 and more, it will usually be stable. Then it won't change that much. So I think identity crisis would be earlier on. Unless you got a very big change in your life, like you got a major illness or you move to a different country where the environment is all very different for you, you have to act differently. Then there may be quite a big change. Otherwise, it will usually be stable. Macam tu. Yeah. So Big Five is given to normal people, and it can't diagnose lah. It can't diagnose any disorders or whatnot. It's just to get an impression of the personality traits that you have or the person who's taking it lah. Okay, so MMPI on the other hand is used in clinic. We use it in clinic to help us to diagnose, to help us to be able to find what are the personality traits that they have, what can we do to help them to in the intervention, so that it helps a lot lah. Yeah, MMPI, but it takes so long. So with the limitation that I have, I would usually Raihan, tolong ambilkan charger jap. Charger telefon. I would usually leave it to my trainees, my master students. They are able to, if you are interested to know how the results are, you can talk to my trainees. I have master in clinical psychology trainees under me in the clinic, and they do a lot of MMPI to learn about this. about assessing and diagnosing a client. So we have this in the clinic in SASMEC, MMPI, where we can know the lie scale. We know if the person exaggerates. If we know if they're tired, we can detect it. And sometimes it can become invalid. It takes about 2 hours to administer it. Sometimes we do it in 2 sessions because it's too long. Okay, so that's MMPI. If you have
I want to ask question.
Sure.
Is there any difference of ego syntonic and ego dystonic in OCD and OCPD? Can I know what are they?
Okay, let's have a look at this. There is a difference as OCD is more ego dystonic and OCPD. May I hear from the presenter first? What she thinks? Siapa tadi yang presenter ni? Last sekali? Aina ke apa?
Saya doktor. Ego dystonic is more something like the something does not align with the self-concept of an individual, meaning that the individual OCD does not align with the individual's belief or concept, meaning that he hates that he have OCD. But if ego syntonic, the self or their ego, if is aligned with who they think they are, meaning that they are perfectionists and they have orderliness, but they think that it is who I am. Like that. Okay. That's what I understand.
Yeah, that's right. It has to do with ego ni kan self kan, yeah. Dystonic ni dia macam incongruence. They know that they shouldn't be that way. They know that this is something abnormal, and they would usually present themselves to the clinic. They wanted to get rid of it, but they don't know how. Yeah, and usually the anxiety will go up even if they do compulsive behavior, which is done originally to reduce it, but the anxiety is still increased. Yeah, so they do more compulsion as well. On the other hand, OCPD ni, they may not even have insight that is troubling them. They think that other people are wrong. Other people are not understanding of them. Other people should be aligning their lives to suit hers, to suit his, because it's something that's a part of me. Ego syntonic is accepting, and there's no conflict within me. Basically they have no insight that this is a disorder. It's something that they like. It's a part of them, and actually it's hard to also change them. So we also involve family members in this therapy with OCPD patients, so that they become more they move along the spectrum so as to accommodate and to the person, and then we also help the OCPD person to also move along the spectrum so that he can be less perfectionist. But it's not as easy lah with a disorder. Personality disorder is not easy to treat. It takes long. It takes long and a lot of skills involved. Okay, I hope that helps. Thank you to the presenter. There is an earlier question about magical thinking in schizoid personality disorder. Can the presenter help with explaining about the magical thinking? Someone asked me earlier in a personal message. Schizoid ke apa Schizotypal. Yang magical thinking tu. Schizotypal. Yeah. Magical thinking, ideas of reference, illusions, and generalization. Magical thinking ni, what do you understand from it? 30%. Anyone can help out as well if you've read about this. Or maybe we can search it for a bit. Actually,
Maybe
I have not
superstitious
seen.
thinking, Doctor.
Macam mana? Wishful thinking, is it? Did you say?
Maybe superstitious thinking.
Superstitious. Can you elaborate further?
Maybe yang related to like macam sihir, santau semua maybe. From what I understand.
Itu yang magical tu ya? Maybe it can be that. Okay. Mental. Kalau kat sini, from
what Google have mentioned is that people who think they can fly are schizotypal. So this is like similar. So it's like they wish they can actually fly.
do some supernatural thing kan? Like flying. All right. I'm also trying to find. I'm not very good in this. Yeah, it should be something that they think that they can, like a magic wand. They can do something that they would want, like turn back into time, or going somewhere, or flying, or getting some magical powers, something like that. That would. It's very odd. Yeah, people would not associate it with something that's normal, but they think that they have the ability to do that. That's called odd beliefs or magical thinking. Magical ideation. Sometimes it's called magical ideation as well. So it's very how do I say? Very easy to detect those with magical thinking, because they're able to tell you when they trust you. Okay, so I hope that helps. Something that they can suddenly ping and then they can do it, and then it's very. The belief is very strong. It's not something that they think it's abnormal. No, this person thinks it's normal and it's real. It's real that they can have that ability. Macam tu. Bukannya macam occasional and they know it's not normal. Not like that. Okay. Very highly pervasive about it. Okay. So do you have any other any feedback from you about this, about mental disorders, about personality disorders?
Doctor, I just want your opinion, your expert opinion. This is a lecture of personality disorders, right? So there's another lecture that we had before regarding personality disorder also, but I think it is a very different spectrum, meaning that the thing that we had before is the lecture is that regarding dissociative personality disorder. So is it interrelated with this one, or is it a totally distinct thing?
May I know who taught it?
Dr. Nizam.
Okay. Dissociative ya. Yang tu, does it fall it doesn't fall under personality disorder tau. Yang tu. Dia macam illness on its own. Dissociative tu yang dia macam split personality kan? Okay, yang tu illness, another mental illness, bukan bawah personality disorder. Dia tak fall under the 3 clusters. Yang tu macam kalau orang biasa panggil split personality lah, macam ada a few personalities on their own. They put a name to it. They have the personality tells them to do this, or sometimes they become a different person altogether. Sometimes they don't eat and drink because that person doesn't want them to eat or drink. Sometimes they speak about things out of their own, like some topics that are just they don't speak about when they are with another personality, macam tu. Because so it's different. It's different from this. Okay.
All right. Thank you, Doctor.
You're welcome. So I hope you can, with this awareness, information that you have gotten, I hope you'll be able to lessen judgments when there are friends who seem to be more aloof, who seem to be more cold, who are not able to socialize the way that you expect them to be, or they're not what you they're just not like you. They're different because people have different makeups, yeah, they're different biological, psychological makeups, and therefore just accept them the way they are, appreciate the diversity, acknowledge that people are very different from each other, and withhold your judgment. It's very important for us to be able to do that, so that we are not easily overwhelmed by our own expectations of others. Okay? When you got married, when you have your a more extended family with your mertua, whatnot, kan, you'll be seeing and knowing so many personalities, and so just accept them the way they are, and be kind to each other. People are just so different, because sometimes we're just angry because we expect them to be different from who we are. But yeah, we can help them to move along the spectrum, but to change people is totally difficult. It's totally impossible. To change them to a different person is impossible. We can help them to tone down a bit. Yeah. So yeah, I hope it helps. Sometimes seeing a friend of mine, how do I say, not married at this age, not even wanting to get married, just happy the way they are, and then other people, other friends or other family members would always ask them, why are you not married? Why are you still single? When are you thinking of getting married? Whatnot. I think it also goes back to like we talked about personality types, where some people just have anxiety when they're with others. Some others just don't want to get married because they're just not comfortable with the presence of other people, want more to live with another person. They have paranoia, they have suspicions, they have their own fantasy sometimes. So just withhold your judgment, because we just don't know what these people are going through. Okay, just whatever it is, just accept them for who they are. There are reasons beyond our own capacity to understand. Yeah. Okay, so with that, then we are better able to help them. If they have problems, we're better able to help them because we have withhold our judgment. Is that easy to do, you think? Have you tried doing that? Any of you tried?
Inshallah.
Inshallah. As doctors, as Muslims, it's very important to be able to do it, okay? Because we want to do a lot of da'wah. We want to help people, and with that, we have to withhold our judgment. Yeah, it's not us to judge. Yeah, even Allah does not judge a person before their end of life. Can still they can change. They can be better than us. They can be better than many people, but But if we put in our judgment beforehand, we already label them as such, it probably puts a full stop to a lot of potentials that they can become, to a lot of more positivity that they can learn, and do always have that in mind, that people can change if they want to be, but we need to help them and support them. It's not a drastic thing that people can change like the magical thinking can. It's not as that. It's not that you can have a magic wand and say boop, change can. It's not like that. So it's gradual. Yeah. Okay. So thank you very much. It's 12:30. Thank you for the presentations. I hope you can email me. And I think you've all got your names and your metric numbers can on the slides. Thank you for the excellent work. And thank you for the attention. Assalamualaikum.
Salam. Thank you, Doctor.
Thank you, Dr. Adira.
Thank you, Doctor.
Thank you,
Thank you,
Doctor.
Doctor.
Doctor, pray for us for tomorrow exam.
Oh, tomorrow is the exam.
Thank you, Doctor. Yes,
Yes,
Doctor.
Doctor.
Oh, dah exam dah.
Doktor.
Komen ni gambar ni. InsyaAllah, ya Allah, pemudahkan semua orang untuk exam, dapat jawab dengan baik. My personality disorder questions are very simple. You don't have to memorize everything tau. Dia simple je. I tengok you punya presentation ni macam, ya Allah, banyaknya benda yang belajar dan baca. Tapi I think the questions are very simple and straightforward. So you can concentrate on the others. It's just like a definition of I think it's simple lah. You don't have to memorize all the indications, the difference between each of the disorders. You don't have to. It's quite fairly straightforward. Okay, so concentrate on the others, which are more difficult, I think. Probably. Okay, all the best. May Allah help. May Allah ease.
Thank you, Doctor.
Thank you, Doctor.
My group members, let's have a 5 minutes break. Boleh? And then we meet again on Google Meet to
Okay,
present.
Doctor.
Assalamualaikum.
Waalaikumsalam.